بسم الله الرحمن الرحيم أعزائي الطلاب السلام عليكم ورحمة الله وبركاته. This is our fourth lecture about the acute inflammation and will be last lecture in this topic, and after that you will be receiving further 3 lectures about chronic inflammation. In this lecture we'll be covering the last category of the chemical mediators of inflammation, which is the plasma protein derived chemical mediators, which includes the complement cascade or complement system, as well as the kinin and the coagulation fibrinolysis system. So we'll be covering this, and after that we'll be touch base with the main morphological appearance of inflammation and conclude this lecture. So, what's the importance of the products of coagulation? Studies performed more than 50 years ago suggested that inhibiting coagulation reduced the inflammatory reaction to some microbes, leading to the idea that coagulation and inflammation are linked processes. This concept was supported by the discovery of the protease-activated receptors, the PAR, which are activated by thrombin. Thrombin is a protease that cleaves fibrinogen to produce the fibrin split clots or fibrin clots. PARs, which are protease-activated receptors, are expressed on leukocytes, suggesting a role in inflammation, but their clearest role is in platelets, in which a thrombin activation of a PAR known as a thrombin receptor is a potent trigger of platelet aggregation during the process of clot formation. So all forms of tissue injury that lead to clotting also induce inflammation. And so they are very much correlated to each other, and inflammation causes changes in endothelial cells that increase the likelihood of abnormal clotting. So in the next few slides, we'll be discussing some of the aspects of these products of coagulation, bearing in mind that you will be having more thorough discussion about these coagulations in the hemodynamic lectures. This diagram shows the clotting fibrinolytic system, which summarizes the coagulation process within the circulation system or within the blood. As you see here, there are 2 pathways, the intrinsic pathway and the extrinsic pathway. You will be studying these pathways in details in the hemodynamic lectures. So I will be focusing here in this lecture on the relevant aspects regarding inflammation itself. And as you see here, the end result of this activation of these pathways is the formation of thrombin, which is by itself is a protease which convert fibrinogen to fibrin clot here, as you see here in the diagram. So to summarize the importance of clotting of fibrinolytic system in inflammation, we see that fibrin clot at the site of injury will help in containing the cause. Fibrin clot also will provide a framework for inflammatory cells. Now, factor 10A will cause increased vascular permeability and leukocytes immigration, whereas thrombin will cause leukocyte adhesion, platelet aggregation, and generation of fibrinopeptides, and is regarded as a chemotactic. The fibrinopeptides are chemotactics and also induce the vasopermeability. So all of these components or of these products of coagulation plays important roles in inflammation, which includes the fibrin clot, the factor 10A, and thrombin. Factor 12A also activates the fibrinolytic pathway to prevent widespread thrombosis. The fibrin split products also increases vascular permeability, and plasmin cleaves the C3, which is part of the complement cascade or the complement system, as we will see later, to form C3A, which lead to dilatation and increased permeability. Again, plasmin also activates the factor 12A and will amplify the entire process of inflammation. So it's all about augmentation and increasing or potentiating the inflammatory process with some of the factor which has some control on that inflammatory process. So thrombin is regarded as one of the potent inflammatory mediators, where it binds to protease activated receptors which are expressed on platelets, endothelial cells, and smooth muscles, leading to B-selectin mobilization, expression of integrin ligands, chemokine production, prostaglandin production by activating the cyclooxygenase 2 pathway, and production of platelet activating factors and production of nitric oxide. So it's regarded one of the potent and one of the efficient mediators of inflammation. The second system of these plasma proteins is called the Kinin System. And these are vasoactive peptides which are derived from plasma proteins called kininogens by the action of specific proteases called the kallikreins. This will lead to the formation of bradykinin from the high molecular weight kininogens. The effect of bradykinin and its impact on inflammation is in the form of increasing the vascular permeability and the arteriolar dilatation, as well as bronchial smooth muscle contraction and pain. It has a short half-life and it is inactivated by the kinases. This diagram is just to show you the interaction and the relationship between the four plasma mediator systems. And as you see here, on the left side is the coagulation or the clotting fibrinolytic system, where it has a close relationship to the kallikrein and the high molecular weight pre-kallikrein Serous, which in turn can activate the factor 11 of the clotting fibrinolytic system. In the middle here, you see the kallikrein with its effect on the high molecular weight kinogen to produce the bradykinin, which is also has effect on the plasminogen to form the plasmin. Plasmin itself is a protease that convert fibrin to fibrin split products. Again, plasmin, it has its effect on the complement system, where it converts or activates the C3 to C3A. So you can see here that all these plasma mediators are closely related to each other, and they are interacting with each other. You are not required to, like at this stage, to memorize these diagrams. It's just all what you need to know at this stage, their interaction and the importance of these specific potent mediators, including thrombin, bradykinin, plasmin, and fibrin. The last of these, plasma protein systems is called the complement system. And again, it has a very important role in inflammation. The complement system, which is also known as the complement cascade, is part of the immune system that enhances or complements the ability of the antibodies and the phagocytic cells to clear microbes and damaged cells from an organisms, and also to promote inflammation and attack the pathogen's cell membrane. So the complement system is part of the innate immune system. However, this can be activated or can be recruited into action by antibodies, which is generated by the adaptive immune system. The complement system هي عبارة عن collection of soluble proteins and their membrane receptors that function mainly in host defense against microbes and in pathologic inflammatory reactions. There are more than 20 complement proteins, some of which are numbered from C1 to C9, from complement C1 to C9, and they function in both in, as we said, in innate and adaptive immunity for defense against microbial pathogens. Several cleavage products of complement proteins are elaborated that cause increased vascular permeability, chemotaxis, and opsonization. Opsonization is the attachment of an antibody or a substance to the microbe to make it more vulnerable for the immune system and to be attacked by other ways of the immune system. This is a process which we call it opsonization of the antigens. There are two main pathways in complement activation. The first one is the classic pathway, where it is activated by antigen antibody complex from C1 to activation into activated C1, which in turn activated C4 and C2 into C4b2A, etc. So this is classic pathway activation. The other main alternative pathway is activated through the microbial surfaces and polysaccharides, and it starts by activation of the C3, where it is converted to C3b, which is the main opsonizing or opsonins. There is a third pathway, which is the lectin pathway, as I will will show you later in the next slides. So in a principle, you can see here these pathways are interacting with each other, leading to or potentiating the inflammation in terms of chemotaxis and increasing integrin affinity, as well increasing the anaphylatoxins, which will lead to vasodilatation and vascular permeability. So again, just in summary, and again, you are not required to memorize all the previous steps in the activation cascade of these complements. But you should notice here that C3A and C5A are potent anaphylatoxins, which increase the vascular permeability and cause mast cells to secrete histamines. The C5A activates lipoxygenase pathway of the arachidonic acid and also activates the leukocytes and increase the integrins affinity, as we just mentioned. And C5A is also chemotactic. So C3A and C5A are important here in terms of increasing vascular permeability, increasing integrins affinity, and chemotaxis. Whereas C3b and IC3b are strong opsonins, as we just mentioned, which will like bind to the microbes or to the foreign material to make it more antigenic and to be recognized by the immune system. The plasmin and the proteolytic enzymes splits the C3 and C5. The membrane attack complex, which is from C5 to C9, has a main function to lyse the bacterial membranes. So again, here to summarize, there are three pathways: alternative pathway, classical pathway, and the lectin pathway. As we mentioned, the alternative is activated by the microbe products. The classical pathway is activated by the antigen antibody. The lectin pathway is activated by the mannose binding lectin. Eventually, this will lead to the activation of the cascade, and the C3b is deposited on the microbe as an opsonization process, and then will activate the different pathways. So the alternative pathway will lead to potentiate the action of inflammation in terms of recruitment and activation of leukocytes and destruction of the microbes directly by the leukocyte itself. The classical pathway will lead to recognition of bound C3b by phagocytic C3b receptor, and therefore potentiating the phagocytosis of the leukocytes. Now, the formation of the membrane attack complex will lead to lysis and destruction of the microbe itself. So again, here to summarize, there are three pathways: alternative pathway, classical pathway, and the lectin pathway. As we mentioned, the alternative is activated by the microbe products. The classical pathway is activated by the antigen antibody. The lectin pathway is activated by the mannose binding lectin. Eventually, this will lead to the activation of the cascade, and the C3b is deposited on the microbe as an opsonization process, and then will activate the different pathways. So the alternative pathway will lead to potentiate the action of inflammation in terms of recruitment and activation of leukocytes and destruction of the microbes directly by the leukocyte itself. The classical pathway will lead to recognition of bound C3b by phagocytic C3b receptor, and therefore potentiating the phagocytosis of the leukocytes. Now, the formation of the membrane attack complex will lead to lysis and destruction of the microbe itself. So we saw that complement system is very crucial, is very important for our immune system, and therefore deficiencies or defects in any of these complements will lead to serious infections or serious autoimmune diseases. These are just some examples to show the importance of the complement, where deficiency of C3 lead to susceptibility to infections and recurrent infections. Deficiency of C2 and C4 will lead to susceptibility to systemic lupus erythematosus, which is an autoimmune disease. Deficiency of late complements اللي هم will lead to low MAC اللي هو membrane attack complex, and they will make the patients liable for Neisseria infections. Decrease inhibitors of C3 and C5 convertase اللي هم decrease in the decay accelerating factor or CD55 will lead to hemolytic anemia, specific type of hemolytic anemia, which we call it PNH or paroxysmal nocturnal hemoglobinuria. Now, one of the important deficiencies is the deficiency of C1 inhibitors, C1 esterase inhibitors, which lead to angioneuritic edema, which can be fatal, which means when these are activated or stimulated, this will lead to edema in the neck and suffocation of the patient, and eventually the death, which can be very rapid in some patients. So we saw that complement system is very crucial, is very important for our immune system, and therefore deficiencies or defects in any of these complements will lead to serious infections or serious autoimmune diseases. These are just some examples to show the importance of the complement, where deficiency of C3 lead to susceptibility to infections and recurrent infections. Deficiency of C2 and C4 will lead to susceptibility to systemic lupus erythematosus, which is an autoimmune disease. Deficiency of late complements اللي هم will lead to low MAC اللي هو membrane attack complex, and they will make the patients liable for Neisseria infections. Decrease inhibitors of C3 and C5 convertase اللي هم the decrease in the decay accelerating factor or CD55 will lead to hemolytic anemia, specific type of hemolytic anemia, which we call it PNH or paroxysmal nocturnal hemoglobinuria. Now, one of the important deficiencies is the deficiency of C1 inhibitors, C1 esterase inhibitors, which lead to angioneuritic edema, which can be fatal, which means when these are activated or stimulated, this will lead to edema in the neck and suffocation of the patient and eventually the death, which can be very rapid in some patients. Here again, a very useful table which summarizes the role of mediators in different reactions of inflammation. And as you see here, for vasodilatation, the most potent mediators for this are histamine and prostaglandins. For increased vascular permeability, histamine as well as C3A and C5A and leukotriene C4, D4 and E4 stands as the most potent mediators for that. For chemotaxis and leukocyte recruitment and activation, tumor necrosis factor, interleukin-1, chemokine, C3A, C5A, as well as leukotrienes B. For fever, interleukin-1 and tumor necrosis factor and prostaglandins, especially prostaglandin E, as we mentioned earlier in the previous lecture, are potent mediators for fever. Pain, prostaglandins and bradykinins are principal mediators for that, and for tissue damage, lysosomal enzymes of leukocytes as well as the active oxygen species. The second and the last part of this lecture is the morphological appearance of acute inflammation. The morphologic hallmarks of acute inflammatory reactions are dilatation of small blood vessels because of the vasodilatation, and accumulation of leukocytes and fluid in the extravascular tissue, as we have already seen in all the previous lectures. So it's all about vasodilatation, increased vascular permeability, and extravasation of leukocytes and the fluids in the extravascular tissue. Now, special morphologic patterns are often superimposed on them depending on the severity of the reaction, its specific cause, and the particular tissue and site involved. So it's variable from site to site, from tissue to tissue, from cause to cause, etc. So the importance of recognizing distinct gross and microscopic patterns of inflammation is that they often provide valuable clues about the underlying cause. So it might be helpful in identifying or predicting the underlying cause or etiology for that inflammatory process. So what are the different morphological appearances of acute inflammation? The first one is what's so-called catarrhal inflammation, where there is acute inflammation and mucus hypersecretion. And the best example on that is the common cold, اللي هي الرشحة العادية اللي بتصير, where you see congestion, mucus hypersecretions in the upper respiratory tract. The second type is what's so-called serous inflammation, where there is abundant protein, poor fluid with low cellular content. And the best examples are the skin blisters and the inflammation within the body cavities, like in the pleura or in the peritoneum. The fibrinous inflammation, where you have accumulation of thick exudate, which is rich in fibrin and leukocytes, and this might resolve by fibrinolysis or can organize into thick fibrous tissue. And the best example of this is the acute pericarditis. This is an example of serous inflammation where it's marked by exudation of cell-poor fluid into spaces created by the injury to surface epithelia or into the body cavities lined by peritoneum, pleura, or pericardium, as we just mentioned. Here, the burn blister, which is a good example of serous inflammation, and you can see here the bullous or the blister, which is filled by cell-poor fluid. Okay, so this is a good examination of serous inflammation. زي ما حكينا, one of the good examples about fibrinous inflammation is fibrinous pericarditis, where a fibrinous exudate develops when the vascular leaks are large or there is local procoagulant stimulus leading to deposition and accumulation of this fibrinous material within the space of the pericardium and leading to this pericarditis, which is التهاب البريكارديوم اللي بيغلف الهارت. The other morphological appearances of acute inflammation also include the suppurative or the purulent inflammation. وهذه probably one of the most common appearances of inflammation اللي هي بتكون either in the form of pus اللي هو يعني العمل أو القيح, where creamy yellow or blood-stained fluid consisting of neutrophils, microorganisms, and tissue debris. The best example on that is the acute appendicitis اللي هو التهاب الزائد الدودية, acute appendicitis. طبعا بنسميها abscess when there is focal localized collection of pus. لما البus بيصير localized and collected, we call it abscess. And we call it emphysema when there is collection of pus within a hollow organ, like in the pleura, for example. We call it emphysema. The last form of this morphological appearance of acute inflammation is the ulceration or ulcer, where there is a defect of the surface lining of an organ or tissue. طبعا mostly this occurs in the gastrointestinal tract or in the skin. طبعا this is an example of a subcutaneous abscess. في عندنا يعني عبارة عن قيح أو عمل موجود تحت الجلد, وهذا زي ما حكينا it's a kind of purulent inflammation. Again, this is an example of lung abscess, which is pneumonia, يعني التهاب بالرئة, pneumonia, where there is a localized formation or collection of neutrophils within the lung parenchyma. This is a gastric ulcer in the stomach, where there is a breach of the gastric mucosa and ulceration, which is again a good example of ulcer inflammation. And the last one again is the foot ulcer, which can occur like in diabetic foot, where they are immunocompromised and more liable to get infections there because of the poor circulation and other risk factors as diabetic patients. And this is, a bad example of foot ulcers. Eventually, if these are not treated well, the patients might end up by amputation of their foot or legs. So now, what are the outcomes of acute inflammation? طبعا ممكن يصير في عندنا complete resolution and back to normal, which is the most likely scenario, with the clearance of the injurious stimuli, removal of exudate, fibrin, and debris, reversal of the changes in the microvasculature, and replacement of the lost cells, layer regeneration. So complete resolution is probably the most likely scenario of these different types of acute inflammatory process. طبعا تعرفوا يعني during life any human being is any person is exposed to quite a lot of different types of acute inflammation because of infections, because of other physical factors, because of foreign bodies, etc. The second outcome might be healing, where there is organization by fibrosis through formation of granulation tissue. Why is that؟ ليش بيصير في عنا granulation أو بيصير عنا healing by fibrosis when there is substantial tissue destruction؟ بتتذكروا لما حكينا بيصير في عنا excessive inflammatory reactions and processes. This might lead to exaggeration of the inflammation and destruction of the tissue, and therefore tissue cannot regenerate, or this will lead to extensive fibrinous exudates, which will heal by fibrosis eventually. So this will lead healing by fibrosis, granulation tissue formation, and fibrosis and scarring. Of course, the acute inflammation might end up by abscess formation. Abscess زي ما حكينا هي عبارة عن localized infection, and in this situation you need to drain this abscess. لأنه even with antibiotics these abscesses become resistant to treat with antibiotics, and the best thing is to incise it or to drain these abscesses and then treat with antibiotics. Or بصير في عنا progression to chronic inflammation ممكن if not responding and it's continuous. This will continue as a chronic inflammation. Again, هون summary للي حكيناه قبل شوية, the outcomes of acute inflammation. You see, when you have an injury, which can be bacterial infection, toxin, trauma, infarction, this will lead to acute inflammation with all the changes, vascular changes, cellular changes, neutrophil recruitment, release of cytokines, mediators, etc. So one of the outcomes can be by resolution with the clearance زي ما حكينا of the injurious stimuli and back to normal function, or this might progress to pus formation and abscess formation, or by healing or healing by fibrosis, or progression into chronic inflammation. Now, so chronic inflammation, and يعني هذه مقدمة للnext lectures about chronic inflammation, can start as de novo by itself, يعني without starting as acute inflammation as a result of viral infections or chronic infections or persistent injury or because of some autoimmune diseases, or it can result from progression of acute inflammation. طبعا what characterizes chronic inflammation اللي هو الangiogenesis اللي هو proliferation of blood vessels and mononuclear cell infiltrate اللي هم الهيستوسايتس والماكروفاجز and eventually fibrosis. Now لما بكون في عندنا chronic inflammation بصير في عندنا healing, this is most likely will heal by fibrosis and will lead to some loss of the function. Again, هون summary للي حكيناه قبل شوية, the outcomes of acute inflammation. You see, when you have an injury, which can be bacterial infection, toxin, trauma, infarction, this will lead to acute inflammation with all the changes, vascular changes, cellular changes, neutrophil recruitment, release of cytokines, mediators, etc. So one of the outcomes can be by resolution with the clearance زي ما حكينا of the injurious stimuli and back to normal function, or this might progress to pus formation and abscess formation, or by healing or healing by fibrosis, or progression into chronic inflammation. Now, so chronic inflammation, and يعني هذه مقدمة للnext lectures about chronic inflammation, can start as de novo by itself, يعني without starting as acute inflammation as a result of viral infections or chronic infections or persistent injury or because of some autoimmune diseases, or it can result from progression of acute inflammation. طبعا what characterizes chronic inflammation اللي هو الangiogenesis اللي هو proliferation of blood vessels and mononuclear cell infiltrate اللي هم الهيستوسايتس والماكروفاجز and eventually fibrosis. Now لما بكون في عندنا chronic inflammation بصير في عندنا healing, this is most likely will heal by fibrosis and will lead to some loss of the function. So we conclude this lecture, and this is the last slide, by summarizing the effects of acute inflammation. And as we have already seen in the previous like 4 lectures, that there are beneficial effects of acute inflammation and there are some harmful effects. And that's why we started by asking whether inflammation is good or bad, because it can be either. It can be very beneficial, where there is elimination of injurious stimulus and dilution of toxins, or facilitating the entry of antibodies, or also facilitating the drug transport and fibrin formation, delivery of nutrients and oxygen, and stimulation of the immune response. However, on the other side, this might lead to destruction of normal tissue and digestion. This might lead to swelling and also inappropriate inflammatory response. And even sometimes, when this might heal, even with healing, might lead to loss of some of the function of that organ or that tissue. And I think by this we conclude our last lecture for acute inflammation. بتمنى لكم يعني دراسة موفقة إن شاء الله، وكل أمنيات التوفيق لكم في المساء. و I think next lectures will be about chronic inflammation.